Yes.
Wonderful, Pooja. I mean, I think it was a great display of different kinds of scenarios and case selection. So what Pooja showed was kind of the imaging devices which you'd use, which would help in decision making, whether to select the patient or not. Now, I'm going to take you all through a series of cases very quickly. I know we are running short of time, is to how these images are going to help in choosing the procedure. So the decision to do the procedure is already there, but how do we go about choosing? So I'll quickly take you all through a case of first a thin cornea, low myopia, normal tomography. As you can see here, patient with just 1.5 diopters of myopia, but is having a thickness of only about 456. And as you can see here, it's only the DT which is in red. Everything is normal. The CBI and TBI are normal. The other eye itself is again a very symmetric thin cornea, -1 power again, 459 thickness. Now, this is significantly lower than the normal accepted cutoff, which we normally use for PRK, which is around 475 to 480 microns. So this was long time back, 2013 or for early 2014 when we first saw this case. And this was the first case of PRK extra that we performed. And this patient, 7 years later, continues to remain, have a stable refraction. And we've gone on to do a number of cases of such patients with a low myopia, borderline thickness or low thickness than what we would normally assume. And combining it with cross-linking has given us a satisfaction. But then, is it really necessary? That is the question which still remains unanswered. Can we just do a simple PRK or SMILE? What does literature say? I'll quickly take you all through this. There's also this question of SMILE extra, because SMILE, still a lot of people do believe is biomechanically superior. Now, there are 4 studies on SMILE extra which say there is comparable refractive efficacy when compared to normal SMILE, and there is possibly improved biomechanical indices on the aura. But the problem is variable energy has been used in the studies from 2.7 to 5.4, and they have performed it even on FFKC eyes with 5.4. While they did not notice any progression to ectasia, there was an increased interface haze, which was clinically significant and even led to a drop in BCVA in some of these patients. However, they did resolve over a period of time, and most of them did recover the vision. PRK extra, there's definitely a more literature on it, and there are 4 studies with comparable efficacy being shown to PRK in a couple of studies. We've been doing it for the past 7 years and over 200 eyes in this group now. And we haven't really seen any long-term flattening because of the CXL itself at the dose at which it's being given of 2.7 joules per centimeter square. Mitomycin C definitely has a role, and these patients, initially though we were thinking that the CXL might reduce the haze, that's really not the case, and mitomycin C needs to be used. Now the problem is in PRK we are doing it right on the surface, which is how we normally do the cross-linking with the epithelium off. But both with LASIK as well as SMILE, with the epithelium being on and the oxygen not penetrating into the stroma, are we really sure that there is a significant cross-linking taking place? Unfortunately, there are not too many head-to-head studies available, and that is one question which remains unanswered. Pooja covered biomechanics beautifully. I'll just run through this one example where we see a patient with a mild suspicion on tomography, a mild IS asymmetry. Overall D is yellow, but not very suspicious. But the TBI was very much on the suspicious side with 0.99. And this was the fellow eye of the patient with a gross KC. However, I would like to produce a contrarian view, but this is a patient with a normal tomography, excellent thickness. I even had to see if the patient has Fuchs dystrophy because it was 650 microns. The endothelium was perfectly healthy. But if you see, the TBI was also normal, CBI was normal, but the other eye had a significant keratoconus. So we are still a little way off as far as ensuring that these TBI and CBI, while they are a step in the right direction, they're not giving us the entire picture, and there are still a few cases which we are missing. Now, to emphasize on the importance of ASOCT and epithelial thickness. Now, this was a patient with a residual error post-LASIK. Original power was -6 diopters, and 5 years post-op came with a regression of -1.75. And when you looked at the epithelial maps, the epithelium was extremely thick with about 70 microns, which is significantly higher than what we are normally seeing. And that almost accounts for the regression that we are seeing itself. But the problem here, what we have to ask is, what kind of procedure are we going to do? Are we going to do a flap lift? Are we going to do a PRK? Because if you do a PRK, how is the epithelium going to grow back? Is it going to become thicker over time? Are we going to see the same kind of regression? So we did a flap lift on this procedure because I didn't want to touch the epithelium of this patient because I had followed him for about 2 years and the epithelium had remained stable. and I didn't know how it would react after the procedure. So I did a flap lift in this patient, and it did work out. This is yet another patient with a minus 6.25 with minus 0.5 cylinder in the initial preoperative period. Absolutely normal scans. And this was the patient's picture in the postoperative period. So after about 1 year, the patient had a regression. Now, the problem is, how do you call it regression? The initial preoperative cylinder was only 0.5, whereas the cylinder right now was minus 1.5 diopter cylinder, which is significantly higher than what he had preoperatively. The pentacam itself did not show any, the cylinder which was captured on subjective refraction. So when we did an epithelial mapping, we saw that the thickness was quite high and it was asymmetric. And this asymmetric thickness profile of the epithelium itself was inducing an astigmatic effect. And like Pooja clearly emphasized, this patient had to be treated properly for potential dry eye, ensure there was no surface inflammation. And after ensuring this, after a period of time, we noticed that the epithelium remained stable in this patient. So the treatment options were either to do a flap lift or a PRK or just a simple epithelial debridement. I just did a simple epithelial debridement, and to my happiness, 4 months post-operatively, this patient had no residual refractive error, and you could see that it was a more uniform epithelium once this patient's inflammation and dry eye had been controlled, and this epithelium remained stable, and the patient had a good outcome. This is just to last slide. I know the time is up. 11-year-old boy with an advanced KC on pachymetry. You can see it's about 430 microns on pentacam. But when you actually did the anterior segment OCT, you could see that the epithelium itself was about 110 microns. So it's extremely important that we image. Epithelium can be a great masking agent in some of these patients. And that's why it's exceedingly important that we start looking at devices which are able to look beyond the epithelium, look at the level of the Bowman's layer and the stroma itself, and tell us how to go about things. Thank you so much for your kind attention.